Thank you for your kind introduction. We have lack of time. We will start. I have nothing to disclose, and uh, Dr. Luan already mentioned that artery-venous malformation can be defined as a directed communication between artery and vein without any intervening capillary system. So in this case of the low resistance shunt, normal tissue ischemia and high pressure venous pressure can make venous hypertension related complications, eventually increased volume of the blood volume in the system can make a cardiac overload. And in this talk, I will focusing on the angiographic classification. Already mentioned by the Dr. Luhan, I will tell you about the Jodo ABM classification. This is still evolving. This from 2006. This year, we published a modified version of the Type 3B ABM, so-called vein first embolization strategy. And this is the type 1 AVM. This is a simple fistula, just a coil embolization of the fistula point is enough. In this patient, you can see one single feeding artery and draining vein, just coil embolization was performed. In this pediatric patient, there is one fistula. So we embolized that point, and follow-up CT shows superficial varicosity resolved spontaneously. And this is the type 2. We have sub-classification of the type 2. One is a big draining vein. 2B is no big draining vein, just a venous pouch with a small draining veins. And type 2C has elongated draining vein and multiple feeding arteries along its course. This is a type 2A, one single draining vein and numerous feeding artery. In this case, we punctured directly to the venous sac, and coil embolization was performed, and the lesion disappeared. This is the similar one, transvenous access. Coil embolization was performed. If you want to treat this using a transarterial embolization, we can make a big parenchymal necrosis. This is a type 2B, no such a big draining vein. This is a direct puncture venogram, and under flow control using a BP cup, after injection of the ethanol, the lesion disappeared. Type 2C had an elongated vein with multiple fistula in the vein wall. So in this case, you can see delayed vein. We punctured the vein and coil embolization. After that, we used ethanol to embolize the feeding artery. And this is the follow-up. How about this AVM? Pelvic AVM, you have a big draining vein. We can think about type 2A AVM. So we wanted to try embolize this patient with a transvenous access from the right internal jugular vein. And we put pipe French catheter and put many coils to slow down the AV shunt. However, there is a residual AV shunt more proximal to the coil mass. So we put more coils to make embolize this long elongated vein. And this is the final result. And also, this is type 3 AVM, multiple fistulae. Type 3A is a micro AV fistulae with the shunt is too small. We cannot access directly. So in this case, we can use transarterial ethanol or interstitial bleomycin injection. Type 3B, we have a multiple dilated vein. We can use a direct stick or transvenous access. This is a type 3A, numerous fistula. There is no room for direct access. In this case, we use the transarterial ethanol, but in this case, it is very easy to make a skin complication. To avoid skin complication, for small type 3A AVM, we are now trying to use bleomycin for interstitial injection sclerotherapy. Using inject the chemotherapeutic agent around the type 3A AVM. In this patient has put AVM with uncontrolled ulcer. After 2 sessions of the bleo interstitial injection, the lesion markedly improved. Let's move on to the type 3B. It is very similar with EX classification as 3B. Is that right? yeah, 2. Yeah. Okay. There is a on ultrasound we can find a dilated vein, and then we embolized the dilated vein using coils. And then this is a direct puncture venography. You can see refluxed contrast to the feeding arterial side. At this moment, we can use ethanol very safely. This is another case. You can see multiple dilated vein and ulcer. This is the initial angio. The first target of the embolization is early visualized vein, and then we put some coil and ethanol. Next session, here is the point, and coil embolization and ethanol reflux, and then here is the point. In our clinic, we prefer to use a coil embolization, but as shown by the Dr. Luan, it is just compression and ethanol injection can be an alternative option. This is the follow-up image. The shunt markedly reduced and the lesion healed spontaneously. This is another type 3B AVM. You can see we can compress the draining vein, and then we can glue reflux to from the vein to some adjacent arteries. And this is the algorithm of how to approach the AVM. Just a simple fistula, it is type 1, is a very simple one. Is there enlarged vein, or can you put the catheter or needle in? If no, this is type 3A. And if yes, is there multiple vein? Multiple vein has a type 3B, and there is only single vein, we can consider type 2. Let's practice again. What is the type of the AVM? This is the renal AVM, huge dilated vein. And you can see one single feeding artery and very big vein and high pressure venous hypertension. We treated this patient with just only type 2 emplarged vascular plug. And this is another case. The patient had a big paravertebral AVM. Draining vein goes to the epidural vein. The patient had a back pain without radiating pain. You can see delayed epidural vein and paravertebral venous plexus. Is it just a simple AVM, type 1? Selective angio shows L5 lumbar artery is the main feeder. However, L4 has multiple feeders. Internal iliac has multiple feeders. So we can consider it as a type 2 AVM, numerous feeding artery and one single draining vein. So in this case, I used the direct puncture and coil embolization was performed, and track embolization was done by using a glue. And this is the final image. How about this case? This is there is no room for direct puncture. This is a type 3A AVM. So we use the diluted ethanol, and this is the final image, improved AVM. How about this patient? Uterine AVM, multiple feeding artery and draining vein. Ultrasound shows some venous cavity. Is this? I think this is a type 2A AVM. So we punctured directly through the uterus and coil embolization and ethanol reflux. This is the pre-MRA and this is the post-MRA. There is no residual early venous drainage. So the patient is cured after treatment. This is the summary of the classification. Embolism materials, we use a coil to embolize the venous coiling, and only transarterial embolization is considered in type 1 AVM. Ethanol is very effective drug, but it is very painful and it has a systemic side effect. So in our hospital, volume of the ethanol maximal 5 ml per single bolus injection, and we wait for 5 or 10 minutes to recover the vital sign to the normal status. And this is the glue can be alternatively used when ethanol is not possible or the amount of the total dose of the ethanol is exceeded our criteria. And bleomycin is a chemotherapeutic agent. It is effective for the vascular anomalies. And however, this drug has a side effect. One is the most common one is skin hyperpigmentation and hypersensitivity. However, interstitial lung fibrosis does not report it in vascular anomaly sclerotherapy series. This is my conclusion. According to the type of the angiographic type, we can get a better outcome and minimize the complication rate. However, in our hospital, the entire complication rate is 20%, including small bulle or some small skin necrosis, and major complication around 3%. So it is still a difficult job. Thank you for listening. Thank you for having me this great TSIR meeting. Thank you.